Good morning. Let's get started. It's a pleasure to share my experience and thought on empty nose syndrome with you this morning. I'm Jang from Seoul, Korea, Asan Medical Center. My practice setting is a tertiary medical center. This is the biggest tertiary medical center in my country, so I always have most difficult cases in my practice. Any ENT practitioner feel troublesome, they send all the patients to me. So I happen to encounter patients with empty nose syndrome. So I came to realize that this is a real significant problem. More than 12 years ago, I had one patient who had empty nose syndrome, and I was managing this patient. One day he committed suicide. So this incident made me going deep into this empty nose syndrome. So I started teaching about empty nose syndrome to my Korean colleagues from more than 10 years ago. So I'm a kind of preacher of the empty nose syndrome in my country. So for that reason, I have many more referrals, and patients are gathering, coming to me, seeking for help. Empty nose syndrome is an iatrogenic version of atopic rhinitis, and this is characterized by a widely patent nasal cavity, and they has history of turbinate reduction procedure. Because we have very distinct fur seasons, patients usually suffer more in the cold, dry winter season. This is Dr. Eugene Kern, is a good friend of mine. And everyone knows that Dr. Kern and Dr. Stankovist from Sweden coined this term for the first time in 1994. I had a chance to meet Dr. Stankovist 2 years ago in Stockholm during the faculty dinner. So the empty nose syndrome is characterized by reduced turbinate volume, nasal obstruction, crusting, painful nasal breathing, dry nose, headache, facial pain, sore throat. We can explain this, but the problem is patients often complain symptoms like suffocation, olfactory dysfunction, loss of concentration, fatigue, anxiety, and sleeping difficulty. So those kind of symptoms make us confusing, as puzzling about this syndrome. Recently, the Stanford group established ENS 6Q questionnaire. They chose 6 symptoms: dryness, sense of diminished nasal air flow, suffocation, too open sensation, nasal crossing, and nasal burning. So unlike the classic atopic rhinitis, patients with ENS complain mostly these symptoms. I personally believe that this is a nice instrument for evaluation of the patient with ENS. When I searched the YouTube internet, I could find something like this. It's so horrible happening. One doctor in China is killed by the patient who allegedly have ENS after the turbinate surgery. Here is a professor from Shanghai. I know that there are some other doctors also who was injured or killed by the patients. It signified the importance of this problem. The diagnosis must be based on the history of turbinate surgery, loss of turbinate volume, but sometimes the patient has not that much volume reduction. Typical symptoms I already explained. There are some supplementary adjunctive diagnostic tests, but it's not confirmatory test. It just can help your diagnosis. Those include a cotton test and trigeminal lateralization test. So ENT surgeons do turbinectomy. Sometimes they do turbinoplasty. They insist that turbinoplasty is safe, but you cannot guarantee, you cannot figure out the exact amount of the reduction of the turbinate volume during turbinoplasty. So I saw many patients who suffer ENS after turbinoplasty, so-called turbinoplasty. For me, it looks like turbinectomy. The problem is, a patient who underwent radiofrequency volume reduction or submucosal diathermy, some patients suffer this condition. So, in 2007 article, Dr. Hauser mentioned that not only total turbinate excision, but also more conservative procedures can induce ENS. This is exactly what I experienced in my practice. So this is my patient. I strongly believe that no one in this room will believe that turbinates are abnormal, but this patient underwent radiofrequency volume reduction, and he suffered a severe ENS. And I realized that if the patient underwent simultaneous septal surgery and sinus surgery, there are much more possibility of alteration of airflow, and there are higher incidence of ENS development. So when we look at the patient's nose inside using endoscope, these are typical endoscopic findings. This is middle turbinate. This is inferior turbinate. It seems the surgeon really hated turbinates. So I don't do this way, but for some reason there are surgeons who hate turbinate a lot and then just remove the turbinate. This is not the case. This patient underwent turbinoplasty, so-called turbinoplasty, but this patient also suffered severe ENS. So this is not a congenital anomaly. This is iatrogenic complication. He has no inferior turbinate. So people are coming to me with this CT scan. Patient from Russia. He suffers severe painful nasal bleeding right side here and dryness. I found the patient with ENS commonly have a comorbid sinus pathology. I think this is secondary to the turbinate reduction. This is another patient. Right turbinate, inferior turbinate is completely removed, and there is a secondary sinusitis. I have a very interesting case. Last year, I have a patient who suffered severe eyeball pain and facial pain. And what I found was he underwent inferior meatal enterostomy. And every time he breathed in, he had pain around the eye. So I closed here with many techniques. And finally, he became free from the debilitating pain. Now, this is the patient I mentioned earlier. This is the patient who visited me more than 13 years ago. And he had a sinus problem, and he also underwent some turbinate surgery. I put him on the medical treatment, and I reconstructed his turbinate here with concave cartilage. One day, his family visited me that this man committed suicide. So it was really shocking experience for me. The instance, we don't know. it's really difficult to study the incidence. But Chabra and Hauser once published that they just estimated about 20% of the patient develop ENS after terminal resection. Pathophysiology is elusive, it remains unclear. But we can easily suspect that it is caused by the alteration of normal airflow and the loss of neural sensitivity can be suspicious, and loss of physiological nasal function, which is exerted by the inferior turbinate, can be thought about. Everyone believes that there is some neuropsychological involvement. We all know that turbinate has its unique function. Its function is humidification and warming and cleansing of the inhaled air. So if this functional organ disappeared, we can easily expect the consequence. So few years ago, I studied, this is my study. I measured the turbinate volume, and I tried to correlate the remained turbinate volume with the symptom severity. So, turbinate volume was measured using CT scan reconstruction. And I also compared this turbinate volume with control group. And there was a significant difference between the turbinate volume between control and disease group. And I found there was correlation between there was inverse correlation between turbinate size, volume, and the symptoms like dryness, facial pain, thick nasal discharge, postnasal drip. Especially, the total volume was inversely correlated with dryness. The anterior volume was inversely correlated with facial pain. The symptoms related to the discharge was inversely correlated with the volume at the posterior nasal cavity. And I also came to realize that the septal perforation can aggravate the symptoms of the patient. So you may think, when you see this city, you may think that this patient must have had a sinonasal malignancy. No. This total septal perforation and total turbinate loss was induced by one of our Korean colleagues. It's really shame. This patient couldn't do exercise. Whenever he do running or walking, he cannot tolerate the inflow of cold, dry air. So I did something to help this patient. For the diagnosis of this strange illness, we can use cotton. This is cotton test. This is not my original technique. This is, I know that suggested by Stanford group. So you put wet cotton on the lateral wall of the nose right here, and then let the patient wait 20 or 30 minutes. Then you can check if there's any change in the symptom. So in their study, in number of patients, they studied the usefulness of cotton test. They checked the ENS6Q score before insertion of cotton, and then they insert it and then check it again. And they found a significant improvement of the volume gain by the cotton. So, and also, it has been suggested that trigeminal nerve function is important in the pathophysiology of this disease. Trigeminal nerve ending distributed the whole nasal mucosa. When we apply menthol, it binds with the trigeminal mucous nerve receptor, and that improve the sensation of airflow. When we apply topical anesthesia, people feel a sensation of nasal obstruction. So impaired intranasal trigeminal function can be a part of the paradoxical nasal obstruction sensation in patients with empty nose syndrome. So there are ion channel called the TRP channel. This is thermosensing nociceptive TRP channel in sensory neuron, and especially the menthol bind to TRPM8 receptor. So this is called as a cold receptor. So it is suspected that the patient with empty nose syndrome has decreased sensitivity to menthol. It means that they have impaired trigeminal nerve sensation. So, yeah, this is a healthy individual. The number here means the dilution of the menthol solution. So, the higher dilution means the thinner or weaker menthol. The lower number means lower dilution. It means much more concentrated menthol. So people with ENS usually has impaired sensation on the menthol stimulation. So this is another study done by a Greek group, and they analyzed the intranasal trigeminal function in patients with empty nose syndrome. And they compared the patient with ENS and patient who underwent turbinate reduction but no ENS, and patient just control group. And they found that the patient with ENS has decreased the sensation of the menthol. I mean that they have decreased the trigeminal nerve function and decreased the perception of the airflow. And recently, the computational fluid dynamics is actively adopted studying the nasal airflow. So this is going to be an interesting tool for better understanding of the empty nose syndrome. Here is a real expert in the computational fluid dynamics from Wisconsin. Okay. There are many studies. The study results are inconsistent, but I chose some studies because this study is much more relevant because this was done in real patient group. Usually the CFD is measured by modeling the nasal cavity, but they just measure the CFD on the real patient. This is their first paper from OSU, Ohio State University, I guess. They found that they happen to have a CT scan of some patient who has pre-op CT and post-op CT scan. And what they found was that the patient who has empty nose syndrome has much more airflow concentrated at the area of the middle turbinate. So this is, and also they found that there's a terminology called wall shear stress. It's a stress exerted on the lateral wall. And they found that the patient who has empty nose syndrome has a significantly reduced wall shear stress, especially on the inferior part of the nasal cavity. And they extended the study and they compared the CFD findings with of the ENS with the normal control group. And they also found that the patient with ENS has, certainly has decreased the increased cross-sectional area than healthy control. they found that they have increased flow rate centered around the middle turbinate, but decreased flow rate centered around the inferior turbinate. They also found, this is the diagram of the CFD finding. This is a healthy individual who has evenly distributed airflow, but the patient with ENS shows much more concentrated airflow around the middle turbinate. And this, this is wall shear stress data. They also showed that patient with the ENS has decreased wall shear force, especially around the inferior turbinate area. And they also analyzed, they compared the CFT data with ENS6Q symptom, and they found there was correlation between the suffocation and openness with the parameters they could get from the CFD. So they summarized. They believe that the normal airflow is predominantly through, especially in patients with ENS, the airflow is predominantly through the middle meatus region, which left the inferior region with much low flow rate compared with healthy control. And they also found significantly reduced air mucosa interaction along the inferior turbinate area. And they found a correlation between the symptom score of ENS6Q with suffocation and nose fills to open symptom. It's in line with my observations. So, people who has significantly reduced inferior turbinate volume tend to suffer those symptoms much more than the patient who doesn't have that kind of problem. Let me start with talk about treatment. Treatment, it's not easy. It's very difficult. We can employ a conservative treatment, some medications, irrigation, ointment, plug, psychological support. Those measures work in some patients, but not in the majority of patients. We are surgeons, so we are inclined to solve some problem with surgical method. So there are some surgical treatment method. The basic idea is creating a neoturbinate in the nasal cavity. The methods are not that much different, but the materials are different. Many surgeons use synthetic material like hydroxyapatite, Teflon, Gore-Tex, Plastipore. But I am a rhinoplasty surgeon, so I don't have any trouble using autologous costal cartilage. So I published my technique using autologous cartilage for the first time. And because this is complex disorder, which may involve pathogenesis related with injury, so regenerative medicine can be an option, can be a future direction. So, but I would say that treating this kind of patient is very, very difficult. So you have to have many options on your hand. And surgery should be reserved for the most severe cases. But we are surgeons. Most of the ENS is caused by me and our colleagues. So we have to keep in mind that prevention is the most important strategy. Now, these are my conservative management program. There are no evidence. I'm just using it. I have an idea that the patient with ENS has low-grade, non-specific inflammation. For that reason, I oftentimes prescribe low-dose long-term macrolide treatment. When I have patient on my first consultation, I usually try this. I would say 1 or 2 out of 10 respond to this treatment. There are some medications which are used for neuralgia, so pregabalin and gabapentin. No evidence. Yeah, no surgeons are using this. I sometimes use amitriptyline. I'm not a psychiatrist, so I don't have a big array of the prescription option. And this is important. Here are my fellow and residents. When they attend my outpatient clinic, they feel that it's like a nasal psychiatric clinic. Yeah, they demanding. I have to discuss. I have to explain a lot to the patient. Let me explain surgical management. This is Dr. House's treatment report. He used acellular dummies on 8 patients, and he reported positive result of using these acellular dummies. This is another report published in 2011. They injected hyaluronic acid. But I'm so scary about this treatment because, as you know, there are many vascular incidents caused by the hyaluronic acid injection on the face. So I'm really scared. So they don't have complication, but I cannot use this technique because if there's any embolization of the small artery, it will block the orbital artery and it may induce blindness. So I don't recommend this. Never, never. And this is paper from China. They used Medpro for treatment, and they also reported a favorable result. Another report using Allodom. And they compared 2 groups of a side-lasting implant and Allodom implant group. They reported favorable result. So this is recent paper. They used beta-tricalcium phosphate implant. I think it's one of alloplastic implant. And this is another study published by Stanford group. They used a porcine small intestine submucosal xenograft. This is soft tissue. It is very long. In my early experience, I used silicone block and I used homologous fascia, and I found I need much more solid material to fill in to make the neoturbinate. And I realized that the allodom and fascia is not enough in volume, and it's rigidity. So I abandoned using those kind of alloplastic and other tissue material. Instead, I started using cartilage. I started treating this patient using ear cartilage first. And then I reported my first experience in laryngoscopy in 2011. This is pre-op. This is post-op photo. So what I did was I made the neoturbinate in order to produce a bulk. It's like a speed bump of the airflow. So this is another patient. I used bilateral ear cartilage. And the problem the patient suffered most was postnasal drip, and it was nicely corrected. This is another lady who suffered dryness and suffocation. So amazingly, she experienced improvement. So yeah, this, and I analyzed the symptom improvement. And I found excessive airflow and nasal obstruction and nasal facial pain was significantly improved. And I also realized that in patients with empty nose syndrome, the mucosa on the wider nasal cavity became thicker than normal. But as my experience built up, I came to realize that using ear cartilage is not enough in most of my cases. So I switched the costal cartilage into costal cartilage because I don't have any problem harvesting costal cartilage because I do a lot of rhinoplasty using costal cartilage. I started using costal cartilage. So I chose costal cartilage when the patient suffer much more severe symptom. And this is a surgical video showing my technique of the terminal reconstruction using ear cartilage. So this is resected turbinate. Here, this I made inadvertent perforation on the mucosa. I raised the mucosa flat on the lateral wall, and then I did septoplasty on this patient too. So I put some bone, but this is ear cartilage. So I tried to make a round bump under the remnant turbinate. And this is technique using costal cartilage. So I elevated the mucosal flap. I made an incision at the piriform aperture, and then you have to dissect very carefully not to violate the integrity of the nasal mucosa. Then I took out costal cartilage using small incision. So I particularly like to use this costal cartilage when I need to reconstruct both turbinates. So I took out some costal cartilage and I bisected it, and I'm designing it. I found that it's a little smaller than my design, but anyway, because this is a rigid structure and this provides enough volume, this is a useful material for creating a neo-turbinate. So I'm inserting the cartilage like this and just close it. I would say that technically this is not a difficult operation. This is straightforward. Everyone can do this. This is pre-op, this is post-op CT scan. Pre-op, post-op. So I tried to do a little bit of overcorrection. Post-op. So I analyzed the outcome of my surgery using SNOT-25. The SNOT-25 include many questionnaire on the nasal symptoms and also symptoms about general well-being. So in this paper, I reported my experience of 31 patients. So generally, the patient's symptoms improved. So the degree of improvement was much bigger in the patient who underwent surgery with costal cartilage. Yeah, this patient has very good improvement, 49-2. This patient has modest improvement, this patient has no improvement. So, as you can see here, the surgery cannot guarantee in success in every patient. So, in these two particular patients, they had no beneficial effect by the surgery. So, this happened to be operated by using ear cartilage. Patient here has a real good improvement, but this patient has rather aggravated symptom after the surgery. So my conclusion of the study was that costal cartilage is more effective getting the improved symptoms. Especially the patient with costal cartilage group showed better improvement of reduced productivity, reduced concentration, and frustration, irritability, and those symptoms. So why I prefer cartilage for terminal reconstruction? Because I feel much more confident using this material, because I can get enough amount of tissue to reconstruct the new turbinate. There has been interesting meta-analysis published by a Chinese group, and they analyzed many papers. Actually, these my study, and they concluded that turbinate reconstruction using autologous tissue was much more effective than reconstruction using alloplastic. So then we come up with the idea where we have to reconstruct. This is paper produced by Professor Tajan Lee from Taiwan. I think it's a very important study. They concluded that you better reconstruct inferior lateral wall. Is that right? Yep. We can think about reconstruction on the nasal floor, on the septal side, but they did wonderful study demonstrating that if we want to have a better improvement, you better reconstruct the lateral wall, especially around, under the inferior turbinate area. So this is the patient who had endonasal microplasty, which was done on the nasal floor. This patient was referred to me from at the clinic, and he had no improvement. So I did reconstruct here again. Limitation of the surgery: it cannot correct the impaired nerve function. It cannot correct the brain of the patient. Regenerative medicine can be future option. There are many regenerative stem cells we can use for this regenerative treatment. Those include hematopoietic stem cell and mesenchymal stem cell. But as you know, it's not that easy to use this stem cell to the real patient. There are very tight government regulation. So I realized that using adipose tissue, stromal vascular fraction can be an easy option to approach. So I used SVF of the abdominal fat. So I did a clinical study, and this is recently accepted in the International Journal of ENT, CEO. So in this paper, I sought to assess the effect and safety of the SVF in ENS, and also I wanted to prove my idea that patients with ENS may have non-specific nasal inflammation. So I did, the inclusion criteria was the patient who has reasonable size of turbinate. to patient like this, I recommend the surgery. But the patient who has a decent size of turbinate, I include those kind of patient. So there are some outcome measures. So I followed them 24 weeks. And I analyzed some cytokine and some of the biomarker. Here is my data. I injected once to both turbinate. 2 out of 9, actually one patient is dropped out, showed improvement. But I couldn't conclude that this is effective treatment modality because just 2 patients is improved. We never know whether this is placebo effect or no. And I analyzed the cytokine, and I found IL-1 beta and IL-8 has increased the secretion level in patients with empty nodule syndrome. So, and it is improved after SVF injection. So through this study, I concluded that SVF injection appears to decrease the inflammatory cytokine. It appears to have a beneficial effect, but we need much more larger scale study to confirm the usefulness of this regenerative medicine. So we all know that this is puzzling, elusive, enigmatic disease, which has many unanswered questions, especially we don't know why only a tiny fraction of patients who underwent turbinate reconstruction, turbinate procedures develops ENS. We don't know. But there are many interesting studies about the relevant physiology. Okay. This is a study published by the French group. They analyzed the patient with ENS about the presence of hyperventilation syndrome. Actually, I have a few patients who visit me saying that I have ENS, but they breathe like this. Yeah, some of them has definitely hyperventilation syndrome. In their study, they could diagnose this hyperventilation syndrome about 77%. This is a really difficult thing. This is a study published in 2000, very recently published study by a Stanford group. They analyzed the psychology of this patient, and they found that this patient has anxiety, depression, way out of proportion. So overall, they reported symptoms consistent with moderate anxiety, moderately severe depression. They complained reduction in productivity at work. So yeah, this is the things making the ENS treatment very complicated. And this is another study showing that the patient with ENS has different cerebral processing of the feeling of nasal patency. Usually, limbic system is not that much involved in perception of nasal patency, but this kind of patient has a strange connection to limbic system. Here are my message. This is radiator generate heat and humidity. It has a certain function. We can easily think about the difference between living in the room with this or without this. I would say that Yeah, turbinate is functional organ. It has a certain function. So if turbinate is reduced, removed, there are possibility of symptoms generated by this absence of turbinate. Actually, this slide was sent from my fellow Eugene Kohn. He sent me this slide. So yeah, I don't think that ENT surgeons are turbinator, but yeah, let me put it this way. If you have asthma, do you resect the lung? If you have a small, minor pain in the fingertip, do you cut the finger? I think idea of turbinate reduction, turbinectomy is kind of strange. If the patient has cancer, the resection is justified, but this is functional organ. They just complain nasal obstruction. There are several other ways of helping this kind of patient. Then why we have to cut, butcher the turbinate? So I hope one day there's a new era, new dawn for the better understanding the pathogenesis and the surgical treatment methods of this difficult disease. Thank you so much for your kind attention. Yeah.